Hello, everyone. Hello, hello. Thank you for joining us in this 50 plus webinar about CROI, the highlights of CROI 2024 that took place about 2 weeks ago in Denver. My name is Damian Cabrera. I'm the program manager for the treatment division here at NMAC. And I'm going to give just a couple of minutes for a couple of seconds for people to join. And while that happens, I would like to mention that NMAC is part of the PACT partnership with the CDC with the Let's Stop HIV Together campaign. It's a really amazing campaign that reflects the community and it has resources about treatment, prevention, stigma, and also places where you can find services around you based on your zip code. And they also have services regarding HIV testing. You can order your own HIV test at your home. And communications that is supporting us today in the background will post those links in the chat. So if you want to find out more about the Let's Stop HIV campaign, make sure that you check out those links. And before I continue, I am very happy to be joined by Jamir Tuten. He has spent the last several years developing programming in support of the community engagement team at Rutgers, New Jersey Medical School Research with a Heart. And he is helping to cultivate a culturally diverse clinical research site. And also recently, Jamir transitioned into a management role overseeing the outreach program conducting HIV/STI testing. And also, I know that many of you saw the promo that we were going to have Jeff Taylor, but he wasn't able to join us today. But thank you to Jules for the last minute for joining us. Jules is the founder and executive director of the National AIDS Treatment Advocacy Project, NATAP, that is based in New York City. It's an organization providing information, education, and advocacy globally on HIV, HCV, HPV, and related metabolic. He is also a prominent advocate fighting for people living and aging with HIV, and he is one of the most knowledgeable individuals that I know in the field. So thank you, Jamir, and thank you, Jules, for joining. How are you doing today?
Absolutely, absolutely. I'm good. Thank you for having me. Uh, I enjoyed the CROI conference. I got a lot out of it. It was my first time, so I'm just happy to be here.
Glad to be here with you guys.
Great to have you too. So thank you again. And before we continue, just so that everyone, to make sure that everyone is in the same page. For those that don't know, CROI is a forum for scientists and clinical investigators where top of the line science regarding HIV and other opportunistic infections is published, and they have facilitated presentations on very, very important discoveries in the field. And it's a conference that has been happening for years and years. And personally, it's one of my favorite conferences to attend to. And one of the really, really important things for us in the community is that CROI offers a community educator scholarship program that is open to leaders in the community, the people that are doing advocacy or educational activities. So if this is a conference that you would like to attend to as a community advocate, please make sure that next year you apply for the scholarship program, because I believe that this is a space for investigators, researchers, people in the clinical field, but it's also to make sure that community is present, actively participating, and actively informing these studies. So now, with further ado, I will pass it over to Jamir, who will be talking to us about some of the highlights from CROI.
Absolutely. Thank you. So I would say that this particular CROI conference, I haven't been to the ones prior to this, but there was definitely a heavy amount of presentation and conversation around prevention, specifically around the newly released injectable PrEP, the cabotegravir injectable, as well as doxypep, the medication that is supposed to prevent gonorrhea, syphilis, and chlamydia. There was a really great session that talked about game changers in prevention around HIV and sexually transmitted infections. And I really appreciated, although these conferences can tend to be really science heavy, I feel like the people who put this together really tried their best to make it appeal and be received at baseline by community members like myself. I've been in this field for probably over 10 years, and I'm not a scientist. I do not understand half of the things that are presented, but they did a really good job at really ironing out the details and painting the picture. One of the things that I wanted to start off by highlighting is that I was a scholarship recipient to attend the CROI conference, and this really prepared me to allow me to be able to connect with people who had experienced the conference before, who have been advocates for the conference and for the actual community engagement scholarship. So, upon attending the plenary sessions and the actual scheduled day sessions, there was actually a lot of emphasis put on meeting as it pertains to community scholars and people who do community engagement, which I really appreciated. They had a space that was specifically for community to be able to network and meet up. If you took a break from a session, if you needed to inquire about something, a lot of the people were always available, very friendly, and very helpful as it pertains to myself being a first timer and not really understanding how things work for the most part. There was also a series of community breakfast conversations that happened virtually that really allowed anyone who wanted to be a part of the conversation to participate, which took place from 7 to 8 a.m. And it allowed for us to kind of have a breakfast conversation, if you will, around the impacts of community on the work that we're doing to prevent HIV, to develop new treatment interventions, this, that, and the third. And so those things allowed me to really understand how community is always at the epicenter and should always be at the epicenter of HIV research and the conversation around cure, prevention, and treatment. So being able to start the day and really start off fresh with people who were scholars like myself and people who have experienced CROI and who are working to really bring attention to the community engagement component of how these clinical trials are facilitated, the advocacy behind really implementing these things in various communities, and how that can sometimes be a challenge depending on when you are. All of those things really helped me center myself before going to the plenary sessions and the breakout sessions that happen during the day. Um, Probably my most memorable experience was participating in the Doxy Pep session, and I say that because doxypep has been the talk of this public health sphere, and it's been really the at the epicenter of us being able to celebrate a new intervention that's helping to keep people from contracting STIs. So I was really interested to really hear why it took so long for us to get to this place of having this medication. As you may or may not know, the medication that's used as doxypep is the medication that has been prescribed for years to people who have contracted syphilis, gonorrhea, and chlamydia. So, in my mind, I'm like, okay, we had this medication for so long that was being prescribed to people who contracted STIs. Why didn't we know? That this would work to actually prevent them. So it was nice to be able to attend a session that kind of broke down the safety, the tolerability, and the data that went into the clinical trials that were facilitated across the country to prove that doxypep would work. Obviously, the clinical trial did not include everyone, so that was atop of the question list, especially as it pertained to cisgender women who identify as heterosexual, as they were not included in the clinical trials. And so there were questions around that. There were also a lot of questions and conversations around the access. And that's something that, from a community standpoint, we always want to talk about the access, right? We want to be able to explain and underscore how people have access to these medications and these interventions to keep them protected, and for people to have options in their toolbox. So there was a lot of conversation around the ways in which they pursued the clinical trial around doxypep, kind of explaining how they wanted to rapidly figure this out so that they can release this as an intervention for prevention. And then there was a lot of talk about insurance costs and how people will actually be able to pay for these things. And this is something that I'm always interested in hearing about, especially as it pertains to people who are living with HIV and being able to pay for medications, and also people who are on the prevention side trying to access PrEP and things like doxypep. So it was really interesting to be able to hear from the scientific standpoint how we got to where we are as it pertains to these medications. And then also, what are the plans to be able to kind of roll these things out? Because I find, and a lot of people who were there, a part of the community scholarship program, agreed that it's great to have these conversations and be able to understand the development of the medication and how it was proven to work. But then there's also that barrier that has to do with how are we going to get this to people, how are we going to get this to everyone, and how do we talk about this in the media, on social media, amongst our networks and with our friends, to get them to really understand how groundbreaking these things are and what they mean for our overall health and wellness. So that was really, 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 really one of the highlights of CROI for me. And also, there were these sessions that were called luminary sessions that we were allowed to sign up for, where we got to actually sit with various principal investigators and people who were actually at the helms of the science, which was really good because it allowed for us to kind of have like a lunch and learn session where we were able to break out with them, have lunch, and really talk informally about the work that's being done behind the scenes to include and incorporate communities, various communities, in the research and the work that's being done to find these interventions. There was also a moment where things got kind of heated because, as community people, we can get a little passionate about defending and advocating for our people, where there was a lot of conversations about how various community engagement strategies and media rollouts, which is educating people about the medications and the drugs, the commercials we see, the social media posts, all of those things were really contingent on where you lived in the world and the level of access you had based on where you were located. So it was really good to be able to pick people's brains who are kind of at the top of this pyramid of science and infectious disease, to be able to remind them that community has to be number one when the protocols are being drafted and presented, when these medications and interventions and the scheduling and the overall plan for being able to implement these things, even in clinical trial form, into communities, and really understanding that a lot of the times access, financial restrictions, and people just not having the opportunity to really understand what it means to participate in a clinical trial that could potentially impact our entire lives as citizens of the world and human beings, and really being able to break it down in a way that doesn't scare people or turn them off or turn them away, but actually enlightening them, and being able to have them be able to have a seat at the table where these things and these conversations are actually happening. So that was one of my favorite parts as well. And I think I'll lastly say that the number one thing that inspired me being able to be a community scholar and being able to be a part of the conversation and attend these sessions is being able to see how many different kinds of people there are in the world doing the work, providing new pathways and ideas and interventions and suggestions to being able to include community and actually make the messaging plain and simple for people who need to get it, and also being able to really be able to say that there are people all over the world, new generations of people who are passionate, like myself, about HIV prevention and treatment, cure research, research around interventions for prevention, and so much more, who are really on fire for this work. And we're asking really amazing and interesting questions. We're proposing various views that even myself hadn't thought about, and different ways to be able to engage communities in the work that we're doing and be able to meet them where they are. So that's probably my favorite thing about being able to attend the conference. And I literally was about to go on to bring up Jim Pickett. Shout out to Jim. Jim, I did not have a chance to meet him in person, but I feel like I know him. He was a wonderful liaison to the community engagement and community scholarship group from the beginning of me receiving the news that I got the scholarship to the end of the conference. Jim, he killed it. Jim, if you're listening, I look up to you. You are a great human being, and I appreciate all of your guidance and support. I don't know how you sleep, because he was like sending messages and we're going to do this, we're going to be here, we're going to do this, we're going to do that. So I really, really appreciated that. And there was a lot of people who I did meet in person from all over the world who are doing really wonderful work to advocate and to fight for things to be just as it pertains to public health, as it pertains to medication access, health education access, and just being able to, again, have a seat at the table. So I really, really felt honored and privileged to be in the room and at this conference with all those wonderful people. And I'm going to take a break to let you talk.
Thank you so much. And something that I know that Jim Pickett was probably particularly excited about was the study about the search dynamic choice, where they essentially provided a cohort of folks in Kenya and Uganda.
Yeah,
They offer oral prep, PrEP, and injectable
yeah,
cabotegravir. Could you
yes. There was a lot of conversation about that. We actually spent most of our, I think it was on my second luminary session that we talked a lot about that. And we really got to hear from, there was one person in particular, his name is Supercharger, who was a part of the group leading the community scholars, who talked a lot about the interventions and the grassroots work that's being done in Uganda and all over various parts of Africa. And I honestly, I gotta be honest with you all. I was so intimidated by some of the things that's happening around the world as it pertains to interventions, being able to break down barriers, to be able to provide people who have gone without access to these various things, and being able to also advocate for community voices, and being able to not make everything be about the US and what's happening in America, but be able to kind of branch out and see that there's a lot of innovative work being done in Africa. It's not just us going over there to help them, but they're actually providing a lot of guidance and resources to be able to support the things that we're doing globally. So I actually got to learn a lot about things that I had no idea about prior to attending the conference and being able to really grasp it all. I wrote like 1,000 pages of notes on my time being there. So it's so many things that I could say, but the one thing that I do want to point out is for anybody who's never attended this conference and is interested in attending, please apply. Please apply for the scholarship. Please pursue this opportunity. This is a wonderful opportunity. This is something that I wanted to do. Personally, my organization did not tell me to go to this conference, they did not tell me to apply. I sought out this opportunity because I really wanted to be able to figure out what's happening globally as it pertains to the work to eradicate HIV, if we can seriously end this epidemic, and what's happening around me that I could kind of bring back to New Jersey to implement as it pertains to getting people interested in this work and understanding what we're trying to do.
Yeah, and I totally agree with you in terms of the level of innovation that you can see that you find at CROI. And at least one of the highlights for me, aside from Doxipep, that I was really interested in seeing the
Hmm.
most recent data was the study about dynamic choice that I was
Yes.
mentioning. That they essentially provided. Several options for PrEP, either oral PrEP, PEP, or injectable cabotegravir. And
Hmm.
what was really amazing was for me was that it was patient centered, and the whole
Hmm.
model was adapted to the needs of the
Hmm.
patients. And they saw an increase from 13 in the standard of care to 79% coverage of the
Yeah.
of the
Yeah.
participants. And I was totally mind blown, seeing this change and uptake
Hmm.
and interest.
Cause
And I think that also the interesting part was they were also able to um, allow to change between either using the pills or injectable. And I
using the
think
pills
that's
or using the injectable, yeah.
Mhm.
Yeah. And I think that's something that, like, that's one of the examples that I like to use in terms of the work that we do. Because not everybody is understanding of research, and research is so stigmatized, and HIV is stigmatized, as we know. So it's really important to kind of baseline things for people, even when you think about the idea of choice, right? That's really what we talk about every day, all day, especially as it pertains to women's health, everything that's happening around public health and policy and politics. It's all about the idea of choice. And that's why I'm excited to be able to have been able to have sat in sessions that really focused and answered questions around that topic, and being able to also acknowledge the fact that although we're excited for something like doxypep, right, we're excited for a medication that could prevent us from contracting an STI, there's still barriers to that. There are still questions and things that we have yet to discover as it pertains to that. And there's still a slew of people who do not know that this thing actually exists. And there's narratives going around that these interventions like DoxyPep and like PrEP as a whole is for a specific group of people when it's really for everyone. So being able to continuously have these conversations, to me, I'll never get tired of talking about this because I'm always um getting to a point where I'm educating somebody who I thought knew more about something than what they actually know. That's why even you all and Jonathan reaching out and asking me if I would be a part of this, it was a no brainer for me to say yes, because I think that's a part of the work. We go to these conferences, we download all of this information, which a lot of it can be overwhelming, but a lot of it is necessary for us to take and bring back to our networks and to our various communities to let them know that there are things happening. It may not look like it may not feel like it at times, but things are actually happening.
I totally agree. And now I'm going to make just a slight shift on the conversation as I'm going to pass it over to Jules, who will be talking to us a little bit about the highlights regarding HIV and aging.
Okay, thanks for that great talk, Jameer, and the
Thank
great.
you.
I just want to add on to that, and you can feel free to comment that several researchers I know have expressed concern about drug resistance with doxypep. So I think it's important for people to know that that issue still remains as a concern to some degree. And further research will be hopefully looking at that, and that's what they said. So, so I was asked to talk about uh, three takeaway messages on older people living with HIV at CROI. So I'm a little different than Jameer. I went to my first CROI in 1996, and I've been covering and reporting on CROI every year since, and attending every since. Not attending the last few years, but reporting remotely. And if you go to my website, the NATAP website, natap.org, you'll find 150 reports posted from this year's CROI. If you want an in-depth coverage and discussion and look at. And then April 5th, NATAP is holding a webinar to summarize and review CROI for an hour and a half, and Dr. David Wohl will be speaking, and it'll be a little more in-depth discussion about all these things that occurred at CROI. So I'm just going to, keep my comments to some three or four takeaway messages for older people living with HIV at CROI, this CROI. And I'd say the number one message, I think, for me, is all the new drug development. There were about 10 new HIV drugs reported on at CROI in uh, various stages of development. There are a couple of once a weeklies, a couple of, uh, um, and so let me mention a couple of them specifically. But I think this is the biggest breakthrough for older people living with HIV. And why do I say that? Well, I say that because um, by now many of you know about older people facing increasing problems around aging and increasing comorbidities, and some studies showing that older people with HIV have reduced mortality, in other words, less survival. One study showed 9 years less survival. And African Americans and Latinos and women particularly suffer with less survival and more comorbidities. So when you start aging and start getting more comorbidities, you start to sometimes, some people get more side effects from the drugs they're taking, the HIV drugs. And that's why we need new drug developments. So, for example, what I'm going to tell you is that I, I would say that the percent of chronic advanced kidney disease amongst people with HIV is somewhere about 6-7%. So for those people, as they get older and older, they may be less able to tolerate the drugs they're on. And every regimen that people are on today, essentially in the United States, has TAF, which is the follow-up from TDF. And TDF was associated with renal disease and bone loss. TAF seems to be much safer. But when you start getting much older and if you start developing kidney disease, which occurs for people who are who have diabetes, they're more at risk, and for African Americans and Latinos, and people who have excess weight, at some point you may want to consider switching to another regimen that does not have TAF. So what we saw at this CROI was the first data from a phase 2 study of bictegravir, which is an integrase inhibitor, plus lenacapavir, which is the every 6 month long acting drug from Gilead. Both of them are from Gilead. So they showed phase 2 results in a daily pill, taking them both drugs in a co-formulated one pill once a day. And the reason that's important is because lenacapavir, up till now, has only been available as a long acting. So here is a one pill every day of bictegravir and lenacapavir, no TAF, no nucleosides, no TDF. So that's a and the results were very good. And now they're going to go into phase 3 and look at it in more in depth to see how broadly it can be used. But I was very impressed with that data, and is a great alternative for older people looking to not take nukes or TAF or tenofovir. And then another regimen, also with the new the Merck drug is islatravir, which is the new NNRTTI, um, a nucleoside translocation inhibitor. It's a new class of drugs. Um, Islatravir plus lenacapavir once a week. They showed good data on that, and that too, I think, is in phase 2, going into phase 3, and that looked good too. So that's a once a week, and also no nucleosides, no TAF, no tenofovir. So then a new Merck drug called MK8527, which is sort of the backup compound for islatravir. So it's the next generation NRTTI, nucleoside translocation inhibitor. And they showed only very early data. And right now they're looking at it for prevention. And it looks promising, but it's early data. But in the future, they're going to look at this for treatment. And it may be more broadly effective than islatravir. So more remains to be seen about that. Now, from ViiV, there were several new drugs. They had two presentations on maturation inhibitors. They have a first and a second generation maturation inhibitor, and it looked promising. It's very early development. Um, and there were several presentations on broadly neutralizing antibodies. So there was one presentation from Gilead with lenacapavir, I think it was, plus nucleosides. I mean, plus broadly, plus two BNAbs, broadly neutralizing antibodies. Or maybe it was bictegravir. I forget offhand. Maybe it was, but it looked good in terms of viral suppression. But there are a lot of questions around broadly neutralizing antibodies that remain concerning. You have to do a test to see if you're sensitive to them, and some significant percentage of people are not sensitive to them. They already have pre-existing resistance, and then the test itself, there's been some questions about its reliability. So, in my opinion, the use of broadly neutralizing antibodies has some questions. And there were a couple of other studies on broadly neutralizing antibodies. There was one with three of them together with no ART drugs other than that. So, having said that, I want to switch to aging specifically. There were two studies on frailty, one from CFAR showing a surprising high rate of frailty in people with an average age of only 53, people with HIV. 58% had, well, 46% had pre-frailty and 12% had frailty at the age of only 53, the average age. Of course, it varied. The average age in the study was probably ranged from in the late 40s to the early 60s. But those are very high rates of frailty. And many of you may not understand what frailty is, but I can tell you that it's associated with severe disability. It's associated with earlier mortality and less survival. And it's a very serious problem, and we're not testing in general in the clinic for frailty. And how do you know if you have pre-frailty? Well, to make it kind of simple, if you're starting to slow down and you have trouble and lack of energy in trying to do your normal daily activities, you're kind of slow, you may have pre-frailty or frailty. So then there were a bunch of studies on inflammation and women, finding that women with HIV have higher rates of comorbidities, higher rates of inflammation, and are really subjected to the potential for reduced mortality compared to men who are aging. And there were a lot of studies on CD4 counts and inflammation and aging. And they all pretty much showed that lower CD4 count was associated with more inflammation, more cognitive impairment, more comorbidities, and perhaps probably reduced survival. So, um, the one last study I want to mention, I think this was from the CDC, showed that mortality for people with HIV decreased, but it increased for African Americans. For older people aging with HIV, it increased for African Americans, and I think Latinos too, but I'm not sure. But for whites, it decreased. So there are all sorts of disparities, and it goes back to my original point that African Americans, Latinos, and women of color are at a distinct disparity disadvantage when it comes to aging and comorbidities. Now, I just want to end by saying that everybody is an individual and not everybody is going to have the same issues and age the same way. We don't study it as well here in the United States, but studies in Europe show that about 50% of older people aging with HIV have multiple comorbidities and have problems, and 50% don't. So, for an individual, we don't know how it's going to play out, and you have to just see how it goes. But it's very important to be aware of all this and keep track of it. And with that, I'm going to stop.
And thank you so much, Jules. And I think one of the things that I wanted to follow up on, because I heard a lot about inflammation, is about I wanted to highlight a story from Rebecca Abelman, because there was a study on inflammation that it the inflammation tended to be more predictive of mortality in women than in men. And I wanted to ask you, what do you think women living with HIV and also men need to know to reduce the risk of inflammation? Because kind of linking it to what you mentioned previously about frailty is that these tests are not necessarily done in the clinic. Like the systems are not ready yet to address HIV and aging particularly.
Well, so that's a great question. And yes, I reviewed her study and reported on that. She had two studies. Her other studies sort of suggested that pregnancies are associated with more inflammation, three or more pregnancies. So it does appear there is a difference between men and women seem to get more inflammation. Now, you really can't test reliably in your clinic for inflammation. Yes, there's the CRP, that's an inflammation test, there's IL-6, but they're mostly research studies. And doing them in the clinic, it's hard to access and they may not be so reliable. But there is a difference between men and women seem to have more inflammation. And it probably has to do with the biology of women, and it has to do with menopause. It appears that post menopause, women have more inflammation, and that affects aging women with HIV. So, yes, that is something that puts women at a disadvantage. And I'm glad you asked that question because there was also a study showing what are the modifiable risk factors for inflammation. And it's nothing new, we've known it, but it's very important. Um, don't drink, don't smoke cigarettes, good diet, and exercise and physical activity reduce inflammation. Those are things you can do to reduce that. Now, I know, and many of you know, that many people with HIV don't practice any of that. So, but that's what the data shows you.
Awesome. Thank you so much. I think that that answers it. And then for the people in the audience, please feel free to put your questions your questions in the chat box. Um, Taylor is from the communications division. She is in the background making all of this magic happen. Taylor, are there any questions from our audience?
We don't have any questions in yet, so y'all please feel free to get those questions in, and I'll go ahead and give them to our panelists to get answered.
Awesome. And Taylor, if you can also put in the chat the link so that people can register to NATAP's webinar that Jules mentioned, that would be great.
Sure
And I
thing.
think I also wanted to kind of make a link on what Jules was mentioning about disparities. In what he was mentioning about mortality impacting mostly Black African Americans, but also what we have seen regarding PrEP and the disparities that we have seen in PrEP, about PrEP uptake, for example, that 94% of white MSM that are recommended PrEP are taking it versus 13 and 24 for Black and African Americans. So it seems that disparities for people of color are across the board in
Hmm.
treatment, in prevention, and essentially anything that we do. And I feel that CROI is a space that we should be kind of inserting ourselves to make sure that not only the data of our communities is there, but that also once that data is out, that the implementation is done with equity. So I wanted to ask you both what are some ways that particularly those who may not necessarily have a formal background in science and research, how they can learn more about the new research, how to get involved, and to make sure that there is representation in research.
I'm so glad you brought that up. And that was before I answer your question, I wanted to just say another component that I left out, an activity that I participated in was the poster session, specifically the poster walks. That was like my favorite part because it really gave us a bird's eye view of what research is happening around the globe. And it allowed us to really connect to different people doing different research work and really seeing what the trends are, what the patterns are. And it was just so many things that I gained from just hearing from various people presenting posters. Shout out to Grace and Dr. Buckbinder and LaRon. I attended their poster walks. It was really informative. And one of the things that speak to what you just said is that we talked about specifically in LaRon's group how a lot of the interventions we saw did not work. And a lot of the things that did not work, specifically as it pertained to prevention, was really surrounded by focused populations who were Black and Brown, who were from Latinx communities. And that was a conversation in itself that we were able to have to recognize that these disparities are worldwide. It's not just something that we're seeing in America. And there's always going to be people um, who are benefiting and growing from the things that we do, but then there's going to be a lot more people who don't know anything about it, and it's really because they don't have the education and the access. Even one of the session points on Doxy Pep talked about the I think it was like over 50 or 60% decline in San Francisco since the uptake of Doxy Pep. But when you think about San Francisco, and the population of people who lived there, pretty much they were considering white, MSM population and pretty much trans females who belong to who are white. So that really spoke volumes to the fact that we're still missing something. There's still a disconnect there. And one of the ways that I feel we never should give up as it pertains to informing people and getting them involved is what we're doing right now. Word of mouth will always be the number one form of marketing and communication as long as we're having conversations and opening the doors 2 more conversations like this one, I think it will be forever gainful as it pertains to this pursuit of us ending the epidemic, figuring out a cure, and being able to just live better. Another thing is one of the ways that I learned, even as a person who works in the field, is from the community and consumer advisory boards. I'm not sure if people have access to those things, if people belong or know where they are, but I would definitely seek that out if you are associated with a site or a clinical space where you go for care, figure out if they have a consumer, especially a consumer advisory board, because I think it's more aligned with the ways in which they are handling you as their patient and as a person who is a figure of the community. And another way is to really seek out people who could be trusted support systems, trusted communities who are engaged already in this work. And that's one of the things that I learned from attending CROI. There's a lot of people who are outside of my network who are doing a lot of great things that I too can learn from, even if they are in Brazil or in Uganda or even in San Francisco. It's things that are happening around us that we really don't know about that could potentially change the game for the communities that are around us. So just really seeking that out and having access to those things can help you understand what we're talking about a little bit more, in my opinion.
So,
That's
so, a couple of things I want to mention that I didn't mention before. Very important. A couple of, there was an oral session on comorbidities where a very important couple of studies were presented. One finding depression associated with heart disease. So if you have pointing out the importance of mental health, and poor mental health is associated with higher risk for developing heart disease. There was another oral session in the same session, a presentation in the same session, showing inflammation in the heart area was associated with increased risk for heart attacks. Very important, there was a study on from the VA veterans finding that older men with HIV were not getting screened for prostate cancer enough, and they had higher rates of prostate cancer and potential mortality. And of note, 67% of the people in the study were blacks. So that raises the point that everybody, whether you have HIV or not, is supposed to be screened for prostate cancer. And if you're an older person with HIV, you should be getting ongoing screening for prostate cancer. And also cognitive impairment and frailty. And, you know, I think Jameer's point is a good one that look for a community advisory board as a way to get involved. It's a grassroots kind of way to get involved. And then there's no substitute for trying to educate yourself. You can go to my website or other websites and learn about treatment. And if you really want to learn, there's a lot to learn, but it takes a lot of work too. It takes a commitment.
Thank you so much. And again, Taylor, if there are any questions please, from the audience, please feel free to
We do have
interrupt.
one. Yeah. So we have a question from Eric Moore. Have there been any studies specific to menopause in cisgender women with HIV? For example, is menopause more severe or does it occur earlier?
Yes, the answer is yes. That's my clear impression from all the past studies, not just from this CROI, but over the last several years. There have been several studies showing that women have earlier menopause, women with HIV have earlier menopause, more symptoms, and it seems to be related for earlier onset for comorbidities as well. Now, a lot of it may be associated with socio-demographic risk factors too. So not just because you're a woman, and not just because you have HIV, but associated with other socio-demographic risk factors like a history of substance abuse. So it's a little complicated, but they all seem to be pointing towards menopause being a risk factor, and post menopause being a risk factor for higher risk for women for comorbidities and inflammation and mortality and frailty.
Thank you, Jules. Any other questions from the audience, Taylor?
Not at this time, no.
Awesome. And one of the things that this is kind of an open question for you both about, was there anything that made you feel optimistic about the future of prevention of HIV or the better management of comorbidities for people living with HIV? Something that you're really looking forward to uh, in terms of science.
I would say for me, having been a part of the clinical trial through years ago through HBTN, that was called 083, that led us to figuring out that injectable cabotegravir for prevention was just as effective as the oral pill Truvada. Um, that had me excited, when it was approved, and, just being able to see our clinic and people coming in to get their shot. It still blows my mind to this day because I remember the day that I started working here a million years ago. And it was like the clinical trial that we had just received, and we had no idea what would happen or become of it. And to now see it as an intervention and medication is that's all the encouragement I need. And I think that Doxy Pep has followed that same pathway because we know that cabotegravir works on both sides of the fence, both treatment and prevention. And now we're seeing the same thing with the doxycycline, the medication that's used as Doxy Pep. So those findings and those interventions have me excited about the science and what's to come. And to Jules's point, there is a conversation around medication resistance, which we are familiar with that as it pertains to treatment and prevention. And there's a lot of things that we still really don't know about how this will impact the landscape of prevention for STIs and even as it pertains to PrEP. We're still trying to figure out how to get everyone on board to understand that this is an everyone drug and not just for people who are gay or transgender. So I'm excited to be able to see science prove us to be, right about the things that we're pursuing and the work that we're doing.
So that's a great question, Damien. So like I said, in Europe they have better data collection, and the studies that recently were shown at the European conference last fall showed about 50% of older people got multiple comorbidities and about 40-50% didn't. So if you transpose that to the United States, it shows you could say that in our older, elderly, aging population, some will develop serious problems and some may not. We don't really know for sure. Everything is individual, like I said. But for people who are developing multiple comorbidities or are at high risk, I'm not optimistic, to be honest with you. No, um, partially because there's no screening in the clinics. Everybody over 50 is supposed to be screened for frailty and cognitive impairment. They're not. People don't exercise. Some people still smoke and still drink alcohol and practice poor diet. But even aside from all that, even if you have a good diet and even if you exercise and even if you don't smoke and you don't drink alcohol, you still can be at risk for frailty and and severe comorbidities, and I'm not optimistic. And then that leaves the question that everyone likes to ask: well, what about people who started treatment ARTs with a high CD4 of over 350 or over 500? Will they have the same arc of problems as they age into their 60s? And the answer to that question is we don't know. The answer is not no, they won't. The answer is we don't know. It's possible that they might have similar problems that the current aging population have. Just because you have high CD4 and undetectable viral load doesn't mean you don't have inflammation. There's ongoing low level viral replication all the time, and inflammation comes from that. And so we don't know what's going to happen to people who are younger now and have started with higher CD4. And lastly, I'll just say that the problem lies in part with the federal government. They've been unresponsive to this problem. They're not really dealing with this. I think they've been dishonest with the patient population and not talking about comorbidities until the past couple of years. And they still don't really talk about it very much. And care in the clinic is really bad. And despite our efforts to try and get the federal government to improve care in the clinics for people who are older, it's not happening. In New York, care for elderly people with HIV is just horrible. It's 15-minute visits with your doctors. They don't have time to spend with you to talk about much else except viral suppression. And many of the doctors are just not educated enough about comorbidities either. And I would say the same about the specialists in New York City hospitals as well, who deal with people with HIV too. And sometimes you have to wait 3 to 6 months just to see a specialist um, uh, after getting a referral from your HIV doctor. That's just unacceptable. So I'll stop with that.
And thank you for those comments. And I think there's one more questions from the audience before we close. But I did wanted to mention some really important points that I believe connect what you both were mentioning. It's about, for example, the data on injectables, or the injectable being this, advancement in technology, and also although there's not much data, or I believe now there's more knowledge and research being developed on HIV and aging, but still both, even though let's say that we have the most updated evidence in research, there are still many systematic barriers for people to accessing the injectable, even at a personal level, even at the organizational level,
Absolutely.
where community organizations are having barriers, and also with the aging
Insurance.
perspective, the clinicians not being able to, not having the knowledge or sometimes even the interest to screen people living and aging with HIV for comorbidities, and there's meaning that there's a huge gap in terms of how we support the community, and thinking about how we turn that into advocating for our own communities to make sure that this happens. And
Very well
before we
said.
close, there's one question from the audience, Taylor.
Yeah, so let me be quick. To Jameer, somebody at LB Lisa asked, as a first time community scholar, what would your advice be for others attending CROI for the first time? You seem to have digested a lot of the science really fast. Any tips for not getting overwhelmed by all the science?
Yes. First of all, try to, if you can, be mindful of the fact that you don't have to feel pressure as if you are forced to attend every single session. I'm a person who's been conferencing for a few years now, both through my organization and independently. I always try to take midday breaks because my brain feels like it's like swelling after a while. So I'll try to take a break. It was a little chilly in Denver, but I would walk
Yeah.
outside and, just get some air. maybe leave the room for a second just to review the program guide and see what's coming up next. I have highlights all throughout this thing, whereas though I was already kind of like, well, I'm going to go here, I'm going to do this, then I'm going to have lunch, and I'm scheduled to go to this poster session. So don't feel the need to pressure yourself to be there for everything, because it's virtually impossible. Another thing is go there with some kind of objective or goal personally and professionally. Like I know professionally, my goal was to be able to connect with some of the people from the PTN who were there, the HIV Prevention Trials Network, because we have up and coming studies, prevention studies we're doing. So I wanted to make sure I got to meet with them on the professional side. And then on the personal side, I really wanted an opportunity to have a one on one with someone who I felt would be a potential good mentor to me, and that was Dr. Laron. And I did have an opportunity to sit with him briefly and speak to him and connect with him. So I kind of met both of my goals. And then my overall goal was to just learn something, meet new people, and have a good time.
Thank you so much. And we are just 2 minutes over, and I wanted to highlight again, make sure that you register for the webinar that Jules was mentioning. The link is on the chat. And also there's a link from AVAC provided by Jim. They were doing summaries of the most important highlights during CROI that are super useful too. So make sure that you check out those. And again, thank you, Jamir, and thank you, Jules, for your thoughts, for your comments. I really appreciate it. Thank you both.
Thank
Thank you
you. It
very
was
much.
great meeting you, Jules. Thank you.
Thank you.
Thank
Bye,
you.
everyone.
Meet you.
Bye. Take care.